Okay, so the first question that we had received from when Dr. Cody was doing her presentation was, what is the age of the oldest living person with trisomy 18, and what is their type?
I don't know. Because other groups existed before us and were interested in trisomy 18, full trisomy 18, we had not really focused on that. And their needs health-wise are just so vastly different from everybody else. So as far as enrollment goes, we focused on people who are mosaic or had partial trisomy 18. So I think there are a few people in their 30s, but I don't really know exactly.
Thank you. Another question that we have is, what are any projects that you are most excited about, and what are you working on for a whole group?
Like impossible to answer almost. So you have this list that we go through every week, long list, and then of course there's the list on tabled list. Wow, and that's like almost impossible question to answer because there are really so many balls in the air all the time. We just turned in a grant to define dysmyelination in 18q minus in a very precise way that would be measures that could be used as endpoints in a clinical trial. So that gets reviewed in January. So we'll see. The basic science side of that is a funded project. It's going on in collaborators labs, but it's a grant that we got through us. So, man, the list. We're gonna go through the list.
It's pretty long, the list. Although I do like the RO3 organoids. That's very exciting, kind of trying to grow a model brain and in the lab to see the precise effects of dysmyelination and what genes are involved. That's really exciting.
Yeah, but they take a long time to grow, so it's moving very slowly. But there's nothing you can do about it. You just have to wait. So, and actually, I'm really excited about the new version of the gene dosage map. But Dr. Gelfond is going to talk about that in his talk. I mean, that's just it's up to our game a notch, I think, in how things need to be explained. That is helpful. So what started out as notes to myself, just so I can keep track of things, is turning into or forcing me to explain in real English, not just cryptic notes that only I know what it meant.
Another question that I have for you, and I'm sorry if you're having a hard time hearing me, everyone. I'm having a little bit of speaker issues, so I'm just going to get really close to my speaker if I see really up on my screen. You had talked a little earlier about aging and chromosome 18. How would you ever start on doing some research about aging, since it's such a wide area of research?
Oh, well, first collecting everybody's medical records, seeing what's going on with them. So just like all the other research, there's two angles to it. One is collecting all the medical records, seeing what's happening to people as they age. But the other thing is to learn about what genes are involved in what conditions that are adult onset and begin watching for first signs of those conditions in people. So, for example, facioscapulohumeral dystrophy type 2, which a gene on 18p is involved in the development of that. We don't know how significant a role it plays, but it's an adult onset condition most often. And so we're doing videos, assessments. Dr. Karkar is in charge of that. And along with a world expert on this condition who's in Rochester, who's also reviewing those videos. So we collaborate with the people we need to collaborate with to make it go further. So I don't know if Dr. Karkar, you want to talk more about that, but.
Yeah, it has been a very fruitful collaboration between our university and our clinical research center and Dr. Tawil, like Dr. Cody mentioned. He's a world authority on FSHD. And personally, it has been a very enriching experience working with Dr. Tawil, sharing thoughts. We are both neurologists, sharing thoughts and, observations about the videos.
Janine, it's Dave Alderpugh. Can you remind us if we had some new medical information on an enrolled participant, where to send that?
Oh, Chromosome 18 at UTHSCSA. I closed my slides. I could pull that up, maybe. So you can actually see it. Just a minute. Okay, now where's screen share? Oh, it's disabled. I can't share my screen.
You should be
Let me
able
make
to now, Janine. I just made you
Okay.
a co-host.
Okay,
Thank you.
there we go. Are you seeing this? Yeah,
Yes.
there we go. That's the email, the phone number, and the website.
Thank you.
And Catherine is the person who collects those.
And you just mentioned the project that Dr. Karkar has been working on. What is the timeline for that project?
Oh, that's a good question. It's ongoing. Everybody's aging. So we're trying to collect as many as we can right now, but we'll probably reassess in a few years. And might be like 5 years or something. But if individuals in the study with 18p deletions start getting a clinical diagnosis by their own neurologist of that, then we'll be on it and we'll reassess everybody right away. So that may define it. But if we don't identify anyone, it might be in 5 years when we do it. So we'll see. It's lots of ongoing decision making based on findings. So this is a lifetime longitudinal study. So it's a commitment on the part of families who participate.
Thank you. That's good to know. All right. I had a question that came up. Does it cost anything to get registered with the CRC?
No. The only cost you might incur is a cost for having medical records sent, maybe, and a cost for getting your blood drawn. So that would be it. We can't reimburse for that, and Quest and LabCorp won't do it unless they're running the tests, and they're not. So you have to sweet talk the school nurse if your doctor's office won't do it, or your neighbor that's an MA or a nurse or somebody that can do that for you. But we'll send the package materials FedEx. You send it back to us, prepaid FedEx. So that's all taken care of. But it has to get back to us in 3 days. So it's a process that you coordinate with Catherine about.
Yeah. Quick turnaround. All right. I had another question that came into the chat. It is, Tough question. Do you think that your research is resulting in less pressure on mothers by their doctors to abort and more awareness that there is hope for the lives of these babies who are diagnosed before birth, and also the pressure to allow the babies to die on comfort care after they are born? I believe this is also a trisomy 18 family.
I have no idea because I don't know those data and if anybody's done that study. So somebody will one of these days, I'm sure.
Thank you
Janine's
for that question.
mentioning the partnership with the Trisomy 18 group, the,
Oh, yeah.
just to mention there is,
Yeah, so one of our projects is we did an online survey of families who had a child with trisomy 18 that lived past the age of 1. They're not part of our normal enrolled group. We just did this survey of them. So we only have their survey answers. We don't have blood, medical records, or any of that. And we published a paper on the cause of death of the individuals over a year. No one had ever, people track how many live past a year, but then they don't ask what happens to them after that. So we published a paper on their cause of death and to see if that was any different. And then we were working on a paper with all the other things. What are their other medical issues? Do they have fewer of this or that? And that's why they survived. And all those data are all analyzed, and the rough draft is on John Kerry's desk. And if you don't know, John Kerry is Dr. Trisomy 18. As so many people in this field, he retired 2 years ago. Yeah, year and a half ago, 2 years ago, so that he could just focus on his trisomy 18 research. So he doesn't have to see patients and deal with administrative junk. There, a lot of researchers are going that route. Just to try to focus on what they want to do in life, and that's their research projects. So, and he's busier than ever. So last I knew, he was in Japan giving a talk. And so he's actually a person who can answer the trisomy questions.
Thank you. This one is for Dr. Hale. What are your thoughts on what is the most important questions to ask for new parents to ask the medical team?
have they seen the treatment guidelines, the management guides? And would they like a copy?
That's a great start.
I mean, honestly, the management guides spell it out for them. It makes it easy on the provider, whoever the provider is, to have at least a place to start. And then the second question, I always encourage families to say when they're meeting a new provider who says, well, you know, this child has X, and that's probably because they have chromosomal abnormality 18, whatever. And the response always needs to be, if my child did not have chromosome 18X, how would you approach their seizure problem, or how would you approach their short stature, or how would you approach their constipation, i.e. just take the chromosomal abnormality out of it and say, this is my child, how would you approach it?
Thank you, Dan. All right, and it looks like we have another question from Kirsten. Kirsten, feel free to also take yourself off mute. I've talked to you a little bit, and you're free to explain your situation a little bit further. She asks, how are these results found when baby isn't in utero? I myself just got diagnosed at 32, and I had a quad screenings for my pregnancies, but nothing came up. However, my pregnancies were a mystery to my doctors. I had too many difficulties. So it looks like the question is how are these results found when baby is in utero?
It's not my specialty, but I mean, the quad screening is just a screen. It's just who might be more at risk. It's not diagnostic, first of all. And secondly, it doesn't diagnose these kind of chromosome abnormalities. It's not what it does.
Xander, get away from me.
Hopefully that answered your question for you, Kristen.
Sorry, I didn't know if I was allowed to respond.
You're just-
Oh, okay. So, yeah, so
Hey,
the
no.
quad screening and stuff like that, like that's just a screening, but like the question above was that like would there be more care or less pressure to abort or something like that? So is the infants that are found to have like trisomy, is that one like visible in just ultrasounds? Is that why they're able to tell when they're, you know, still inside the mother, as opposed to like if the child, like me, like as I was growing up and there were just different symptoms and stuff, that's why my mom was taking me to all of these doctors, because I was actually my mom's biggest baby and I was born on date, but I just stopped kind of growing. So is it like visible in ultrasounds for some babies?
I think prenatal stuff is absolutely not my area of a specialty. But I mean, there are soft features that they see that aren't typical, which makes them do an amniocentesis. And that's what would diagnose a chromosome abnormality.
Okay.
Oh, Dr. Hale.
They're also able to recover fetal DNA from mother's blood now. And I forget the fancy name for that. But having nothing whatsoever to do with chromosome 18 abnormalities, we now are getting more and more referrals of children with other known chromosomal abnormalities like Turner syndrome, like Klinefelter's, that are identified based on infant or babies, fetuses DNA present in the mom's blood. And I know nothing about that technology, but I know that they're picking up abnormalities of chromosome number, and more and more of the OB-GYN practices are doing that.
Is this like a mutation, like kids who are born with it? Is it a mutation kind of like dwarfism? But then if you have it, you then carry the genes to give to your kids?
No, it's not a mutation like dwarfism because that's a single gene mutation. But yes, you have if you have a chromosome 18 abnormality, statistically, you have a 50-50 chance of passing it on.
Okay. Because I'm positive my son has it, because he's the reason why I kind of kickstarted to Refind an Answer, because he was just following like my medical pattern like to a T.
Well, you're not the only adult that found out they had a chromosome 18 abnormality once they had a child that was born, because times have changed. The testing is better. It's more accepted. It's, I guess, more accepted by insurance. And so more people are getting it done. And when more people get it done, they find out by more people who are less affected, which then means they start checking people who are less affected. And so it's this process of you have cause for having the test, that bar is going down and the number of tests are going up. And so that's why sometimes we have a few families in which the mom got diagnosed after the child was born.
Because like another reason we went and started looking is because my symptoms from childhood, they are progressively just getting worse. Like I've always had, they just told my mom it was like loss of feeling or stuff like that, but like they still, I don't think I've even seen full specialist of what I need to see, but like tremors have started like pretty bad. Like the skeletal dysplasia kind of, I think, came to a standstill, but the neurological stuff with like tremors and loss of feeling and like just chronic pain and stuff like that has continually gotten worse.
I'm wondering, maybe Dr. Karkar could speak a little bit on tremors and chromosome 18 conditions.
Well, but he doesn't even know what she's got, so he can't really answer the question on the call. So unless it's a general question or address, but
Yeah.
that's the problem with specific answers for specific people on a call like this.
Yeah, tremors come in many different types and forms. There are action postural tremors. These are tremors that are, brought on by performing certain actions. There are resting tremors. That's the kind of tremor that people with Parkinson's, for example, have. There are intention tremors. These are tremors that individuals with cerebellar conditions would have. So tremors, and there are medication-induced tremors as well. Certain medications, are known to enhance a predisposition to tremors. Enhanced physiological tremors, we call them. When it's due to a medication. So tremors are very non-specific, and so is tingling. I heard you mention tingling. It could be due to a peripheral nervous system problem, or it could be due to some central nervous system issue. So, but like Dr. Cody said, it's hard to really say for sure if one doesn't have a specific genetic diagnosis. Yeah. Mm-hmm. This way, once one has that, one might be able to correlate, symptoms with certain genes that might be correlated or causative.
Thank you, Dr. Karkar. All right, and then just to give everybody a quick, we're about 7-8 minutes left. If you have a Q&A, if you have a question, please feel free to put it in this chat, or you can take yourself off mute and ask anybody directly right now. Janine, do you want to talk a little bit about the Gabriel Miller Kids First project?
Just start over. I talked about that in the last talk. What to say different about it? Actually, the funding from this project is really helping us get all those scanned medical records, and the various Excel and Access data spreadsheets and databases into a single REDCap, is what it's called, database, and really helping us get started in, ramping up that process. Okay,
Yeah.
John.
Yeah, and we're working on it. And what it's also helping us do is kind of standardize the way that we identify the findings, like hearing loss or specific, every system in the body, actually, from the teeth to the eyes, the ears, the respiratory, cardiac. We're putting him in sort of this precise new medical coding, and the Gabriela Miller Foundation is also sharing some of this information for within a larger database, so that we can have a bigger set of people to draw from to identify, which structural birth defects are associated with which genes, and why some people might have a larger impact relative to others, even if they maybe have a similar deletion or duplication.
Yeah. And then it looks like Tam has a question.
I do.
Sorry, Tam.
And I'm just curious at the timing of bone density studies of the tetrasomy kids. So I know, like, we kind of got those first ones. Has anybody done second ones to kind of see if they're getting worse or if it's stabilizing? Does it plateau, or is it something we need to, are we expecting a change?
I haven't looked at those data recently, but we probably really need to make a note, John, or whoever, re-ask people what if they've had another bone scan. But early on, when we were doing this, those that had already been on treatment were getting better.
Oh, really? Okay.
Yeah, yeah.
Okay. So, and that might send a direct message to Dr. Hale as well, because I mean, we went from normal bone density to severe osteopenia in the number of years we waited to do a second one. And in between, he developed diabetes 1.5, which is not related to the chromosome. So I'm curious if those could be connected, or all the tetrasomy kids, gonna get worse as they age.
So I can answer the first part of that, which is that poorly controlled diabetes can certainly be associated with a wide range of problems with many organs and tissues, including bone loss, but well-controlled diabetes is not.
Okay.
So from that perspective,
and I would say David's is very well controlled. He's not using insulin regularly. So
right, that's what I'm saying. So yeah,
he's so underweight. So it just surprised us that all of a sudden he had a couple of breaks. So they did another one, and she was like, "Oh, he has severe." And I was like, "Well, he had normal the last time we did it." So it was very unusual. I was curious if that was going to be everyone's trajectory, or is it just he's an outlier as usual.
And how many fractures has he had?
He's had 2 in the last 3 years, which is why they went back and did another one.
Yeah, but that one of those is because his dad drives a golf cart like
That's true.
Well,
both of them were impact injuries where a typical person.
Yeah, but what the general advice is, it maybe, I mean, there are certainly medications to stabilize bones now, and generally 2 fractures or a single vertebral fracture is reason to at least have that discussion with the endocrinologist.
An endocrinologist, okay.
Yeah.
All right, I'll make a note. Thank you.
Okay, we have time for one more question. And then what I'm going to be doing is creating breakout rooms based on syndrome. So you can join those right after we wrap up. One more question if anybody has one. And then we're going to be moving into syndrome breakout.
I saw a question from Talia Grossman about what were the good sides of individuals with chromosome 18 abnormality. And I guess I have 2 answers. All of their sides are good. But the second answer is, I think being different for whatever reason it gives you some empathy for other people that are different. And I must say that when I go to the conference and watch many of the genetically unique young adults interacting with each other, they are far more accepting than many of their peers are about the foibles of others. It doesn't bother them. They don't understand exactly what their friend said. They are happy to have a friend and happy to be communicating. So